Hello, everyone. My name is Jonna, and I'm going to be the moderator for today's webinar. I am here with Dr. McMillin. He is a board-certified, fellowship-trained ophthalmologist and refractive surgery specialist at Campbell Cunningham Taylor and Hahn, as well as Campbell Cunningham Laser Center. We are super excited to have you all join us today. We are covering a great topic, which is the EVO ICL. If you have any questions throughout, please hold those to the end and you can chat those to us in the questions pane. I will have those read to Dr. McMillin at the end and he will address those for us. So without further ado, I'd like to pass it over to Dr. McMillin.
Thanks, Jonna. Can everybody hear me? Jonna, can you hear me?
Yep, we're all set.
All right.
Sounds good.
Perfect. Jonna, do I need to hit the start broadcast now?
We're covered.
We're covered. Okay. It still has like a pop-up box there. All right. Well, thanks everybody for tuning in so we can chat about kind of an exciting option for folks that previously maybe haven't had good options for vision correction. This falls into kind of the elective refractive surgery category, along with LASIK, which I'm sure a lot of people are familiar with. And so this is just sort of the next iteration, the next generation of improvements in refractive surgery, and it's exciting because there's a lot more available to patients than in the past. So, the reason that we're here today is just that you're tired of glasses and contacts, and there's a lot of great things about wearing glasses and contacts, but I'm sure, as most folks are familiar, a lot of hassle and in really high prescriptions, the quality of vision is often not great through glasses and contacts, depending on your prescription. Oftentimes, people have been told that you're not a LASIK candidate, and I'll go through why that might not be the case. And in the past, there was really no other options. If you weren't a LASIK candidate, it was right back to glasses or contacts. So this is, some other options here. And then, of course, it's expensive to have glasses and contacts, and there's that ongoing expense that people are often concerned about. And just the fact that a lot of my patients tell me, no matter what we do for them in terms of refractive surgery, if we can achieve the goal of getting out of glasses, it's just sort of the freedom in their life to travel, to use off-the-shelf sunglasses, and just not have to worry about one more thing to do every day with glasses and contacts. So it's important that you understand what exactly a glasses prescription is. And the word we use is refractive error. Basically, a glasses prescription is called a refraction. And so when you have a refractive error, it just means that your eye is out of focus. It's the way that your eye is made, and it does not focus light appropriately. So light comes into the front of the eye just like a camera. It goes through the cornea, and then it goes through the pupil, and behind the pupil is the eye's natural lens. And the goal of the front part of the eye, the cornea and the pupil and the lens, is to focus light onto the retina. The retina is like the film in the camera. So just like a camera, if it's out of focus, it doesn't matter how good of a camera it is, the pictures are going to be blurry. And so nearsighted people tend to focus light too soon. And so we have to correct that with glasses or contacts. Far-sighted people is just the opposite. Typically, the light focuses too far behind the eye, and so we have to use plus-powered lenses to bring the focus point onto the retina. And then people that have astigmatism, you can be nearsighted with astigmatism, you can be far-sighted with astigmatism, or you can just have astigmatism. Astigmatism is when your eye has unequal curvatures depending on the direction of the light. It actually splits the light into two different focus points. And so the lenses that correct astigmatism are a little more complex because they have multiple curvatures to correct the abnormal curvature of the eye. So when we think about vision correction and we think about the cornea and the lens, we really have two basic categories now of surgeries that will fix glasses prescriptions. The first category is what most people are familiar with, and that's laser. And laser works on the cornea to reshape the cornea. And those procedures are LASIK and PRK. Both procedures have been around for a long time. They have a really proven track record, and for the right patient, they do a great job. The next generation that we're seeing more and more are lens implant surgeries. And so these surgeries really open up refractive surgery for a whole new group of people who otherwise aren't good candidates for LASIK or PRK for various reasons. And with these procedures, we're not using any lasers at all. We're actually using lens implants to modify the prescription of the eye. So, brief review on LASIK. LASIK essentially reshapes the corneal curvature. Typically, we're flattening it with nearsighted prescriptions or steepening it with far-sighted prescriptions. And we use two lasers to do that. There's no blades, there's no scalpels. It's all done with laser. The first laser makes a flat. It's called a femtosecond laser. And the second laser reshapes the eye. That's called an excimer laser. This is a really highly customized procedure, and it is programmed down to the 100th decimal place to correct not only the prescription, but other underlying um, visual aberrations that aren't detected with a normal glasses prescription. So the quality of vision with modern LASIK is really fantastic. LASIK is not a reversible procedure because it does permanently remove some tissue from the cornea, um, but when done safely, the cornea is still very strong. LASIK is a very similar procedure or PRK is a very similar procedure to LASIK. However, there's no flap involved. So we only use one laser, that's the excimer laser, and we reshape the eye with that laser. Now, because there's not a flap, the healing process is longer with PRK. And for that reason, many patients, we will choose LASIK over PRK because of the shortened healing time. But in some patients, PRK is still a good option, especially those with thin corneas or some mild dry eye. So that brings us to the EVO lens. And this is something that has been around for about 10 to 12 years in Europe. So we have really good safety data, at least for 10 years on these patients. EVO can correct prescriptions much higher than LASIK can. It can also correct high amounts of astigmatism. Because we're not touching the cornea, we aren't worried about the cornea being thin, which is often a reason why people can't have LASIK or PRK, or if patients have large pupils, which in some cases can be a concern for LASIK. So essentially, the procedure involves numbing the eye. There's a small opening made in the eye, and then we place a folded lens implant in the eye and tuck it underneath the iris, and the incision heals without any sutures. Think of this lens like a very soft, flexible contact lens. This lens will stay in your eye throughout your life until you develop a cataract, which typically occurs between the sixth and seventh decade of life, at which point it would be removed, and then you would have cataract surgery in the later years of life without any additional problems related to the ICL. So I'm going to show you a quick video from Star, which is the company that makes the ICL, which will hopefully give you a little better idea of exactly, kind of what's involved with the ICL procedure.
Dr. McMillin, the audio is not coming through, so if you want to describe it, go ahead. I would maybe just highlight what you were saying there.
So as you can see from the video there, that the lens actually sits behind the iris, so it's not visible at all to any person looking at your eye, except maybe a really skilled eye doctor. It's amazing how thin and clear the lenses are, and if you're not really looking for it, you can actually miss it in someone's eye. Like I said, ICL is approved for very high prescriptions. So it starts at about a -3 and goes up to a -20 with up to 4 diopters of astigmatism. The highest ICL that I've treated up to this point is someone who was a -21, and we were able to nearly correct all of their prescription. But the neat thing is that if you have a really high prescription, say a -24 or something like that, you can have ICL and then a LASIK procedure to correct the small residual amount if you're a candidate for LASIK at that point. Typically in the lower prescription ranges, like a -3 to -6, we still really lean on LASIK and PRK because in those patients, it's really a kind of an easier way to get the same result. But when we start getting in higher prescriptions, especially up, the -8s and above, we're really finding that the quality of vision with ICL is just as good and maybe even better than it is with LASIK. Certainly, there's lots of patients in the -13, -14 and up range that have really excellent quality of vision with ICL, and they really would not be candidates for LASIK. One thing that I do hear from patients that they like about ICL is that we can remove the ICL. If for some reason there's a problem with the vision or quality of vision, we can remove the ICL and your eye will go back to its original prescription. You can't really undo LASIK or PRK. Once you have it, your eye is forever changed. And so that is one nice thing about ICL. I tell patients I can't undo the surgery, but I can remove the ICL if there's an issue. So just the benefits of ICL is the excellent vision day and night, permanent yet removable. We don't really worry about dry eye with ICL. We do worry about dry eye with LASIK. And so if patients do have dry eye and that's the reason that they've not been a LASIK candidate, then we can use ICL. There is a layer of UV protection in the ICL, which does protect the retina from the sun. It's a quick recovery, and in the future, when you need cataract surgery, your cornea has not been modified, which can affect your ability to have advanced lens implants with cataract surgery. So with EVO, we leave all those options open for you in the future. The lens cannot be seen or felt inside the eye by the patient. So let's take a look at a side-by-side comparison of all three of these procedures. So what you'll see is that we really achieve excellent vision with ICL, LASIK, or PRK. The surgeries are relatively short. With EVO ICL, we do this surgery in the operating room, and we typically do one eye at a time. And the surgeries take, I think 30 minutes is probably longer than usual. It's more like a 15 to 20 minute procedure, about the same for LASIK and PRK. One of the differences is that we typically do LASIK and PRK on both eyes simultaneously, or ICL, I like to separate them by about a week. Recovery is quick. My ICL patients are usually seeing better the next day, and the same with LASIK. PRK, it can take up to 4 weeks for the vision recovery. So for that reason, we do less PRK because it's a slower recovery. ICL can be removed, LASIK and PRK cannot be undone, and ICL provides the UV protection. So that really summarizes the most common surgeries that we do for folks under the age of probably 45. When folks get into their 40s and above, typically we will start doing a different procedure called a refractive lens exchange. Now, this is very similar to cataract surgery, where we remove the natural lens and we actually replace it. When we do an ICL, we leave the natural lens in place and place the lens in front of it. When we do a refractive lens exchange, this is for slightly older patients who are really too old for LASIK, maybe too old for an ICL, but not yet old enough for cataract surgery. One of the benefits of a refractive lens exchange is we can treat farsighted people, hyperopes. We do not treat farsighted people with ICLs. We do treat some farsightedness with LASIK, but for farsighted treatments, if you're over the age of 40, a refractive lens exchange is going to be the best surgery. For nearsighted people, if you get over the age of 50, typically we'll stop doing LASIK and PRK or ICL, and we will start doing a refractive lens exchange. One of the benefits of a refractive lens exchange is that in patients who have lost their ability to see up close, which typically happens after the age of 45, we can use trifocal lens implants, which can give you the near vision and the far vision back. So I think that's a brief overview of the 4 most common types of refractive surgeries that I perform. Um, it really depends on you. It depends on your eye and the specific measurements of your eye. We've got a lot of tools in our toolbox now, and ultimately the outcome that you want is clear vision. And my job is to help guide you, educate you, and come to a decision that you're comfortable with about the procedure that's going to work best. LASIK isn't for everybody, PRK isn't for everyone, ICL isn't for everyone, and refractive lens exchanges aren't for everyone. But all of those surgeries performed in the right person can have amazing outcomes. And I've sort of dedicated my career to trying to provide those for patients. And it's just really exciting to have more options. It just means more options available for patients, and more people are able to be free from glasses and contacts. So people always ask, does it hurt? I am amazed at how little I hear from patients about pain and discomfort. I think that ICL patients tend not to have much in the way of pain or discomfort. Your eye is numb during the procedures. The recovery is typically quick. I will hear things like my eye feels a little scratchy or gritty. Maybe it feels a little dry the next morning. Most of my patients don't even take Tylenol or ibuprofen after the procedure. LASIK and PRK, similarly, most patients don't have pain with the procedure itself. Now, PRK can have a little more discomfort, and that does set it apart from LASIK. But PRK patients will get pain medications after surgery, but LASIK patients and ICL and refractive lens exchange, we do not give pain medications because they're just not necessary. What are the risks? And this is specifically of ICL. Any surgery out there has risk, and we can really mitigate that risk, but unfortunately, it will never be zero risk. So things like infections can occur, elevated eye pressure can occur. Some folks can have glare, especially early after surgery, or even early cataracts. All of those things are really uncommon things, and there's really good safety data. And if you come to see me for a consultation, I'll go through all of that in really a lot of detail with you, and so you really understand what sort of risk you're taking. The risk is low, it's not zero. However, living the world as a highly nearsighted person, as you may realize, also is not without risk, and I hear that from patients every day. One of the things that we talk about a lot is residual glasses prescriptions. So what if I have surgery and I still need glasses? While that's not very common, it is possible that you could have surgery and still have a small glasses prescription left over. Usually I can address that with either a secondary laser procedure. Some of my patients are just really happy to have a much smaller glasses prescription that they only wear occasionally or when they need it. So it really depends on the unique situation, but that's a very addressable issue. So typically patients for ICL are between the age of 18 and 45. We can go a little bit older depending on the patients. When you get older than 40, you'll start to lose your near vision. And so even with an ICL, if you've lost your near vision in your glasses or contacts, then you'll still need either reading glasses or something to help you see up close. ICL can only correct the distance vision. Now, if you're under the age of 40, you'll still have the full range of vision. You'll still be able to see near and far, just like you do with your glasses or contacts. But in those older patients, not really that old, but older than our typical elective surgery patients, will need reading glasses. Now, for patients that are eligible for a refractive lens exchange, we can use trifocal lens implants and help restore the near vision that they may have lost. Insurance, unfortunately, does not cover refractive surgery as a whole, and that includes LASIK, PRK, and EVO ICL. They are considered elective and they are not considered medically necessary because you can live your life with glasses or contacts. But if you don't want to have to do that, and as we certainly understand that, then ICL or any of these procedures can be a good option for you. The first step is just to check with us, come in for a consultation and we can kind of walk you through your different options. There are some options for financing. That's a question that we always get, and my staff knows more about that, and they can certainly educate you on that. So if you're interested and you want to know more, we offer free consultations. There's no charge for the visit. We understand that there's a lot of questions and it's a really big decision to choose to have elective refractive surgery. I absolutely love my job because I get to take care of folks and just sort of walk you through this process and see the beginning to end. And it's really fun to be there with you and be part of the process of achieving good vision. Hopefully that lasts, a long, long time for you. Feel free to give us a call. The number we would want you to call is, you can call any of our numbers that you find on our website, but the main number to the laser center, which is where we do these consultations, is the 865-588-3937. It's right here at the bottom of this slide. You can also click on the website here, the ccteyes.com, and you'll be able to find lots of information about refractive surgeries, LASIK, PRK, as well as all the other things that our practice does. This is just, a small area. This is really my area of expertise, but our practice offers, full spectrum eye care. And so feel free to look around there. Always happy to answer questions. So that pretty much wraps up all that I have. I'll kind of keep it short. If there's any particular questions from those listening in, you can feel free to ask or type them into the chat there, and I can address those now. If not, feel free to call and voice those questions to my staff, and they can usually answer the questions. And if they can't answer the question, they'll ask me.
Perfect. Thank you, Dr. McMillin. I will leave the chat open here and give everybody a chance to send in the questions here for a moment. Great. It looks like there may be no questions today. You did a great job. So we'd love to have you all come in, just like Dr. McMillin mentioned. We will also make this recording available afterwards, so check your emails. We'll send a link out to this, so if you'd like to share this with any friends or family, please do so. And as always, we'd love to see you in the practice at any point. With that, we'll go ahead and close out the webinar unless there's any questions. I'll give it one more second here because I always feel like one comes in right at the last second. Okay, perfect. Well, thank you everyone for joining today, and we hope to see you in the practice soon.